Thank you for joining us for this webinar on success stories addressing social needs in primary care with a focus on food. My name is Carissa Miller. I'm the Program and Communications Specialist for Montgomery County Medical Society. I do have a few housekeeping items before we begin today. We have muted all participants at the beginning of this call for sound quality purposes. To mute or unmute yourself over the phone, press *6. On PC, it's Alt-A, and on Mac, it's Shift-Command-A. We do welcome your questions. We recommend submitting them via the chat feature. For Q&A, we'll start with pre-submitted questions, then progress to questions submitted via the chat feature, and then at the end, anyone on the phone, we encourage you to unmute yourself, hit *6 to ask that question. In today's program, we will take a look at the role primary care can play in improving access to healthy food, which positively impacts mental health and chronic conditions for patients. This will include an examination of how food insecurity can impact chronic and mental health conditions, assessing and addressing food security in the primary care setting. We'll discuss available partnerships in Maryland that can support primary care practices and review other opportunities to identify and address social needs in primary care. We couldn't have offered this program without our co-hosts, MCMS Physician Connect partner organization, Netrin Health, as well as our presenters from Meals on Wheels of Central Maryland and the Maryland Primary Care Program. So MCMS thanks them for their collaboration on this program. And now I'd like to turn the presentation over to Jennifer Shelley from Netrin Health, who will introduce our speakers today. Jennifer?
Thank you, Carissa, and we thank Montgomery County Medical Society for co-hosting this event with us today. We are looking forward to a very useful and relevant discussion about food insecurity in Maryland and the role that primary care can play in tackling this issue. Let me just take a couple minutes to introduce our panelists. First, we have Stacy Payton, who joins us from Meals on Wheels of Central Maryland. Thank you, Stacy, for participating today and collaborating with us on this event. Stacy has been with Meals on Wheels of Central Maryland for 9 years. Today, she serves Maryland seniors as the Director of Client Engagement. She manages the day-to-day operations of the Client Services Department for 6 regions throughout Central Maryland, including Baltimore City and County, and Anne Arundel, Carroll, Hartford, and Howard counties. Her experience in managed care, case management, and social and human services enables her and her team to consistently deliver quality and relatable care to clients from all walks of life. Thank you, Stacy, for joining us. I also want to welcome Chad Perman. Chad is the Program Director for the Program Management Office. He co-designed and now manages Maryland's partnership and daily operations with CMS to implement the Maryland Primary Care Program. Chad is a key advisor to the Maryland Department of Health and on health transformation and population health initiatives. He previously served as the Director of Health System Transformation within the department's Office of Population Health Improvement. And prior to working with the state, Chad served as a consultant with Health Management Associates. Thank you, Chad, for dedicating your time to the Maryland Primary Care Program and for joining us today. Our final panelist and another co-host for today's webinar is Arumani Manasundaram. Arumani is the founder and CEO of Netrin Health. At this time, Arumani, let me hand the microphone to you so you can get us started.
Jennifer, thank you very much. I'd like to thank again Montgomery County Medical Society, Chad for joining us, and Stacy for joining us today. So we're going to get started. I'm going to try to share my screen. Jennifer, let me know if you can see it.
I can see it. If you can increase the size of your slide, that would be good.
Great.
Perfect.
Carissa, thank you. Jennifer, thank you. This is an important topic for us, even pre-pandemic, and definitely making a huge impact during the pandemic. Many seniors throughout the United States and Maryland are regularly facing challenges accessing food due to mobility and other transportation limitations. And given that we are having social distancing measures in place, these challenges are certainly likely to be heightened. We see that every day as we are care managing our patients in the community. felt that this was an important topic for us to address and also showcase how we have made tried to make an impact in the community here in Maryland. So a little bit about Netrin. Again, we are a value-based care organization here, built from the ground up to help primary care practices move towards value-based care. We currently serve our ACO and our care transformation organization in and around Maryland. We're serving all the counties of Maryland and have served close to about 70 practices between the ACOs that we manage, other ACOs, and the care transformation organization, and have served little over 30,000 Medicare lives in Maryland. And our approach, we have our own platform for care management, for analyzing data and data analytics. We have our own interdisciplinary care management team that addresses chronic care management, has the capability to address transition care management, the pharmacy in terms of medication management, behavioral health integration, telemedicine, remote patient monitoring. So today I want to address again one of the social determinants of health that we are facing here in Maryland and throughout the United States. I want to start with 3 success stories to showcase that as how we have made an impact in food insecurity here in Maryland. These are some of the anecdotes and stories that we have gotten from our care management team. Wanted to share and start out with that. The first story is about an 80-year-old patient. Our care team member was in touch with the patient's family member and found out this patient was very much homebound, had many chronic conditions, and prevented her from making her own meals or going out to get meals on her own. Our care team member connected, made a referral to the Meals on Wheels program, and got the meals that the patient needed. And this is a quote from a patient. I'm really, patient's daughter, I'm really glad to have this program started for my mother. This will definitely give me a break each day. The second story is a 76-year-old patient who has diabetes and struggling with high blood sugar levels and needed to be taken care of on a regular basis and needed a diabetic specific meal plan. Again, we connected this patient via the Meals on Wheels program, and they started the program that was very specific for this patient based on being diabetic, and that would tailor for weight loss and controlling the blood sugar levels. Again, a quote from the patient: I did not know this program was around because I live alone and pretty much stayed to myself, but I'm glad that this is an option for me. Every single patient that our care team has referred to program like the Meals on Wheels and others, other programs, I think they're extremely grateful. Even pre-pandemic, during the pandemic, it's making a huge impact. The third story is from a patient. I had a hard time managing my health conditions without easy access to meals. I really appreciated Sony, our care team member, walked me with every step of the way to sign up for the meal delivery service through the county, which I did not know existed. And the physician is a quote from a physician that our care team provides the critically necessary meals to our patients. I think there have been a lot of patients who have ended up in the emergency room because of lack of food and lack of managing their conditions because of lack of food. I think this program has certainly made a huge impact. So food insecurity in Maryland. Maryland is one of the most expensive US states to live in. An average home price is about $794,000. Half a gallon of milk costs about $2. Monthly energy bill is about $173. The doctor visit about $96. And according to the Maryland Food Bank, about 1.5 million Marylanders are food insecure here in 2020. And at least 1 in 20 Maryland seniors face hunger daily. It's unimaginable when you hear some of the stories of our care team. It is real, and we see that impact on an everyday basis. So COVID-19 associated hardships such as unemployment and poverty, we are seeing an uptrend of this increasing food insecurity here in Maryland. We also are seeing that because of social distancing, it's definitely heightening the challenges for seniors and their family members who are unable to normally visit them, make them the meals, or deliver the meals. That's not happening. There's mobility limitations and also other transportation limitations. So according to Feeding America, about 16 to 17% of Maryland will be insecure in 2020. That's a fairly huge number uh, given what we're facing here in Maryland. And because of reduced access to healthy food and other disease onset of new diseases or making their existing comorbidities worse, we feel there's going to be an increase in healthcare utilization, overall cost, and utilization. Here, as part of the various programs that we are doing, including the Maryland Primary Care Program, it's about the total cost of care and reducing unnecessary ED visits. So this is certainly a huge, important social determinant of health issue that we need to address. And we're here to showcase how we're doing that with some of our partners here in Maryland. We've also seen that food insecurity is linked to poorer health and diet-related conditions such as diabetes, obesity, depression. Yes, in terms of mental illness, food plays a huge impact in terms of how it impacts the mental illness, asthma, chest pain, hypertension, and other ADL limitations. So in terms of Netrin, built from the ground up, it's about whole person care. So how do we assess the person from the clinical conditions, the various social determinants of health, and get the patients the help that they need? Initially, in addition to the practices that we work with, we create a longitudinal patient record for our patients in assessing their existing clinical conditions and other social conditions as well. Get them the referral that they need, clinical and other social, create customized assessments, and make sure that we get them connected in the community level with the resources that they need to provide the whole person care. This includes behavioral health issues, various other social conditions as well, and addressing the various social determinant of health issues for our patients. Because in addition to the various clinical factors, other factors impact the health and well-being of patients, more so in seniors. So we work with our patients in making sure that they get all the other aspects addressed, whether they need transportation services, if they need their utility bills paid, behavioral health, getting them the DME, the prescriptions if they need it to be delivered to their homes, the financial support, housing, and last but not least, the meals that they need, a vital component for their daily living. According to the WHO, the social determinants of health contribute to about 70% of the person's health outcome is attributed to the social determinants of health. And the traditional care, such as the one-on-one medical care the patients get in a doctor's office, contributes to only about 10% of the overall health and wellness of a given patient. So this is definitely not to be discounted, and more so now during the pandemic as we address with our patients. So how do we find out that the patient needs some of these social services? From the very beginning of the program, we evaluated the various social screening tools, and we landed on the health leads, and health leads as one of the social screening tools. We have created posters. Pre-pandemic, we had created posters for the exam rooms, the doors, created various postcards, and trying to create the social screening tools integrated within the EHR and the workflow of the practice. We are asking the practice to ask the various social screening tools questions. In the last 12 months, did you ever eat less than you felt because you didn't have enough money for food? And a short list of questions we narrowed down with the health leads questions. We have the practices ask them as part of their assessment. As part of bringing on a patient during our care management process, we also do the social screening tools. And during that process, we assess to see what are the various social determinants that impact a patient, so that we can address, in addition to the various clinical factors, other social factors that the patient needs. So I think whether it be us or anyone else, whether the practice, it's very important to integrate the social screening tools within the daily workflow of a practice, of a CTO and others, so that we can assess. Yes, in certain cases, the patients are not comfortable in answering some of their issues. I think we need to be sensitive to some of those factors and be trained to address based on some of the factors. We may need to see if they're alone, even pre-pandemic, more so now than ever before, and try to infer from some of their behavior, their utilization, how their health is, to try to get them the help that they need. So I would say really stress every practice, every CTO out there to make sure that you integrate the social screening tools for the patient. We have created a lot of awareness for the patients. Even pre-pandemic, we created various postcards, we created mailers and posters for doctors' offices about the various referral programs, the health lead questions, and we created posters talking about the Meals on Wheels programs and other referrals that we could do. I think it's important for the providers to know about it. It's important for the family members and the patients. We use the EMRs at the practice level to also push some of this information to the patients via the patient portal so that the patient is aware. We have created some of these flyers that's also available in the big screen TVs in the examined rooms and offices of the practices, so that they know of the various services that's available to the patient. It was important to educate them pre-pandemic, more so now than ever before. If they're not coming to the practices, we need to get this information available to the patients to know that this is available to them. I think it's extremely important. When our care team members are talking to the patients or their families, we help them understand some of the resources available to them in the community and what we can bring them as part of the program that we offer. Practices who are out there, and including the CTOs, you can certainly discount some of these services as part of your care management fee to make sure that the patients are making use of this. We are an ACO and a CTO. We are incented to keep the overall healthcare costs down here for our patients here in Maryland. So we try various ways to reduce that unnecessary utilization, and we look at the risk score. We look at the COVID, the risk factor that's there in the CRS system. We create our own risk score based on the ACG risk score, based on the claim data. We use the HCC risk score, the social screening tools, to see which patients may need interventions from other social interventions. We do referrals in different manners. The practice can certainly refer via the CRISP system to the Meals on Wheels. They create a telephonic encounter to our care teams, and then we create a referral to the Meals on Wheels. We try to find which agency is available based on the county of the patient, based on the availability, and based on urgency. In some cases, the agency that we're looking for may not service the counties where the patient is, so we'll try to find other agencies. Given the pandemic, I think we need to try to find various resources. At Netrin, we have created our own resource directories for various counties and for various services, social interventions that we need that's available to our patients. We also try to make that available to our practices so that they are making that available to the patients and needed. We have tried to go in and find out in a geospatial map where the practices that we service are, where the patients are, and which service area they belong to, and which service center can actually service based on those zip codes. Again, I think this is an important component for a patient's health and well-being, and I'm extremely grateful to our next speaker from our Meals on Wheels program. Stacy, I'm going to turn it over to you to showcase how you're helping our patients here in Maryland. Stacy?
Okay, thank you. And is everyone able to see the screen?
Not
I don't,
yet.
I don't
Okay,
see it yet, Chris.
sorry.
And I have the slide. You got them? Okay. There we go.
Okay, and can you see it now?
Yes.
Okay.
Yeah, hold on.
Yes?
Yes.
Oh,
I
okay.
can see the slides.
It didn't
Okay.
come through yet.
Oh,
I think we're just getting some background noise.
yeah, because,
Go ahead.
oh,
Yeah. You can
okay.
go.
Okay, I'm sorry.
That's
Okay.
okay.
So I'm Stacy with Meals on Wheels. And just a brief talk about our mission. So our mission is to enable people to live independently at home through the provision of nutritious meals, personal contact, and related services. Meals on Wheels' vision of Central Maryland will be widely recognized as a leader providing of innovative, quality service, nutrition, and support services for homebound elderly and disabled in Maryland. Um, and just so you know, everyone knows, I know a lot of times people have questions about Meals on Wheels. And yes, we definitely serve seniors, and they're who we serve predominantly, but we serve anyone who is homebound and unable to prepare meals. So that could even be a pregnant mom that is home on bed rest. So there are no age limitations or restrictions for Meals on Wheels. And so we've been serving the community since 1960. It actually started with two individuals who were delivering door to door to homebound people in Baltimore. Today, we provide a daily hot and cold meal that is low in fat, low in sodium, and low in concentrated sugar. So I wanted to start off by saying this slide was pre-pandemic, because now, because of the pandemic, we've definitely seen an increase in our services and in the clients that we're serving. So typically pre-pandemic, we were making about 25,000 meals a week, and we actually make those meals right in Hollandtown. We have a staff that comes there every day and they make these meals. So we were making 25,000 a week. Now we're making 75,000 a week, just with that increase. Meals on Wheels was open Monday through Friday. Now we are open Monday, 7 days a week with our executive director who is there all of those days to all of the staff. Like, we have basically chipped in. We help out the kitchen staff, and we have different shifts. So we have packing shifts Monday through Sunday, and we have 3 packing shifts. And all the packing shifts last about 3 hours. So we're making these meals, putting them in the boxes, and then they go out into our refrigerated trucks, and they're there until delivery the next day. So I'm also saying that for anyone on this call who is interested in volunteering and helping or giving some time, it's a great cause. And we've had so many volunteers, which is also a wonderful thing during this pandemic. It's probably been over 3,000 to 4,000 new volunteers just in these couple of months of people who just really want to chip in and help. So they've been out delivering meals for us. We have school students. So people have just really been stepping up to Meals on Wheels to help us with this huge need that we have now. The meals that we provide, so now the meal service, we deliver to the clients once a week instead of the daily delivery. And they receive frozen meals. So the client is able to select either 1 box of frozen meals that contain 7 or 2, so a total of 14 frozen meals. So we went to this number 1 because of the needs. And then number 2, because of the safety for the clients. We wanted to limit the exposure for the clients and also for the individuals who are delivering to the clients. Before the pandemic, we had home delivered meal clients of about 1,800, and now we probably have over 3,500 and growing. So the meals provide 2/3 of the daily recommended dietary. I don't need RDA, recommended dietary. What is it? Recommended dietary.
Allowance, the recommended diet daily allowance.
Yes, I'm sorry, that's it. Daily allowance for people over 60. So the meals are prepared every single day in our commercial kitchen in Highlandtown. And we do have specialty meals, so we provide meals that are modified, texture modified. We have a no pork, no fish, and we also have Korean meals, which we've now been doing for the last 2 or 3 years. And we also have kosher meals. The kosher meals are obviously provided from a different kitchen, a kosher kitchen, and we've been doing that for years. So here are the service areas that Meals on Wheels provides. We serve Baltimore City, Baltimore County, Carroll County, Harford, Howard, Anne Arundel, Montgomery, and Prince George's County, and a really small part of Montgomery County. So we have 6 regional offices. So in each one of those counties, we have regional offices, and there is an area manager in their office, and there's also a client support staff. And those individuals are the individuals who are on the front line, and they are taking applications. So they're doing applications with the clients. They're answering the phone calls from clients and any other agencies who are reaching out to Meals on Wheels for help. We have 21 distribution sites. So the distribution sites, the meals are made daily at our office in Highlandtown. And then we have paid drivers, probably about 30-something paid drivers. So these drivers take the meals to these distribution sites, and then volunteers come to the distribution sites. There is a site coordinator who oversees that whole operation, and the volunteers come in and they are handed a route sheet. On that route sheet, it's the client's name, the address, the phone number, and the meals that that client will be getting that day. And that's how those meals are delivered. A lot of our distribution sites are out of churches that just from the goodness of their heart and because they love Meals on Wheels and what we do, they let us use their spaces to be able to utilize this and what we do on a daily basis. So we say approximately 2,000 volunteers, but add probably about 2,500 more since pandemic. And the programs and services. So of course, everyone knows that we have the home delivered meal program, but we also consider ourselves to be more than a meal. So we have a grocery assistance program. So the grocery assistance program is all volunteer based. So we have volunteers who sign up to actually go grocery shopping for clients. And because of liability reasons, they don't take the clients, but they do go to their houses, they get the grocery list for them, and they go to the grocery stores for them. They're also able to pick up prescriptions for them if the client needs some services like that. Sometimes they may go once a month, they may go twice a month. So it's sort of up between the volunteer and the client, how often they would be going grocery shopping for them. We do put a limitation on it. I think it's no more than maybe 3 times in a month. And the clients seem to really like this, and then they do not have to be a Meals on Wheels client. So we do have offer that grocery assistance program to seniors who are not also a Meals on Wheels recipient. And then the housing upgrades to benefit seniors. This is a program through Baltimore City where seniors are able to get housing upgrades. We also have a Together in Care program, and this is a program for success. And this is something that we have partnered up with Johns Hopkins Bayview with. So basically, they refer patients who have specific diagnoses such as diabetes, congestive heart failure, and when they refer these clients, they pay for the meals for 90 days for the clients. And within that time, that client is able to get durable medical equipment. They are assigned a case manager. And then also when they get their daily deliveries, the drivers or the person who is delivering has a handheld device, and they're able to ask them specific questions that are geared toward whatever their diagnosis is. And some of those things can get escalated up. So, if they answer a certain thing, like, I'm not breathing well, or, like I've not taken my medication in some time, then that gets escalated up to their primary care manager. And so we have seen that this program has been very successful. So people have recognized how important it is when you integrate healthy foods for individuals, how this allows them to stay out of hospitals, to not be frequent flyers in emergency rooms. So we've been doing this for 2 years, and it's been amazingly successful. And then we have more than a meal service, crisis intervention. When people go and deliver, they also have forms that they're able to fill out if something is not, doesn't seem right with the client. We call it a client concern form. So anytime there is a misdelivery for clients, we give that client's emergency contact a phone call. And that's something that we promise everyone when you receive Meals on Wheels. And it's really assuring to family members who may not even live in the same state. Now they know that there are going to be another set of eyes on clients, and then if their loved one has not answered the door, that we're going to be calling out. Sometimes we get reassured and they're like, oh, I'm sorry, they had a doctor's appointment or someone came to take them out. But there definitely have been times when we have found clients on the floor, and we have saved lives in this. So that's one thing, like I said, that Meals on Wheels definitely, takes to the heart, is that we want to make sure that the clients are fine. And then we have isolation reduction companion visit. This is, of course, before pre-pandemic. We also had people who volunteered to be companions for clients. We also had a partnership through Baltimore City where they had seniors who are paid a stipend, and they are companions with some of our clients. And they're able sometimes to give family members a break. Someone, who is a caregiver, and maybe like an hour to just go out, and do something because someone is there with their loved one. It's really appreciated. And we also have case management. So pre-pandemic, we would, any client that we put on service, we would also do a home assessment with them. So the first 30 days that they're put on service, we go out and we do a home assessment with them. And then after that, they get a home assessment on an annual basis. And all of that information is put into our system. And through that, we generate resources to help them with things. Maybe they need to get a free phone. Maybe they need help with utility bills. So things like this is what we're able to help them with. And that's what we do in our case management department. And I did leave out one of the programs. We also have Kibble Connection. So Kibble Connection is where we have partnered with the SPCA, and they donate food. And so any of our Meals on Wheels clients, when we sign them up for service, we ask them would they like to receive dog or cat food. And if they say yes, we also have volunteers, and that volunteer will go, and I want to say it's 4 times a year, and they give them deliveries of dog or cat food. And all of these, once they sign up for Meals on Wheels and they start receiving the meals, the grocery assistance program, the companion program, and the Kibble Connection is of no added cost to them. So there's nothing that they have to pay for these services. And so what we found is that, with the costly acute care utilization increasing as society ages, it's compounded by social determinants of health, including social isolation and food insecurity. So in Meals on Wheels, we believe the solution to that is to eliminate food insecurity, to decrease social isolation. And, you'd be surprised, but people delivering to clients is definitely a big help with that. There are clients who the only people that they see are the people from Meals on Wheels who are delivering food to them. And a lot of the people who deliver to them, they get so attached to these clients, and the clients get also so attached to the people that are delivering. So they, they develop these relationships. And sometimes, they do, extracurricular activities. Like they'll say like, Miss Smith loves me, to bring her oranges, like, or she asked me to pick up her mail, or she asked, could I take something to the post office? And so, people don't have a problem in doing that. So we know too that food insecurity and social isolation is very important to the health of seniors. Because now we're not able to go inside of homes for their protection and ours also, what we do now for all of our clients is they do receive wellness phone calls. So we're calling them 2 times a week, to just see how they're doing, to see if it's anything that we can help them with, to see if they have any questions or any concerns. And I've talked to a couple of the clients, and they so appreciate, those phone calls and someone reaching out to them and, talking to them and caring about their well-being. And so back on what I was saying, basically to reduce all acute care utilization through the provision of home delivered meals, personal contact and related services. And, it's very interesting to know that 1 year of comprehensive service per client costs less than 1 day in the hospital. So if that doesn't bring it home, I don't know what does. And so we've teamed up with the CRIS in referrals, and how that works is that they are able to send referrals Monday through Friday. Those clients are contacted within 24 hours of receipt to verify the information. And the things that determine the eligibility would be the service area and the needs of the client. Once we determine that they are in a service area that we service and that they do have a need for the meals, service is started. And for any client, when we start this service, it only takes 48 hours for them to start Meals on Wheels. So that's one thing we pride ourselves on, is that there is no long wait when someone wants to start service. Within 48 hours, we're able. We've also even started even before then. Sometimes, if we talk to a client and they just don't have those 2 days to be able to wait, that is definitely something that we're able to do, is to go ahead and get them a delivery. And then we're also able to make referrals for them. And if ineligible, so if the clients are not in the service area, we already have a list. There seems to be a lot of people who need help in Montgomery County. And we do service Montgomery County, but such a small part. So we already have a list of the available resources for Montgomery County. So we're giving them that phone number. And one of the thoughts I thought about today is we're not keeping track of that. So we may even just start asking the clients, hey, if this resource, is fruitful for you and you do start service, do you mind giving us a call back? And this way we'll have that information. And that's something that we'll also be able to report it back to Chris, because then that's also still a success. And so how we're doing it now is, all the information is recorded. We have an intake specialist, and all she does Monday through Friday is to go over and take applications for service with clients. So she is the ones that the CRIS referrals come to directly. Her name is Kate Wagner, and she is amazing. She's the most patient, person for anyone calling on the phone. She gets very involved, and so she makes up a report, and basically it says the status of every person, whether she's not able to contact them. And we do make 3 attempts at contact. So she attempts to contact them 3 times. All of that goes in our system that we use. And then this information is pulled together and is sent to our partners from CRIS on a monthly basis. And that's it.
Stacey, this is amazing work. I think very few people know the great work that your group does and the volume. It certainly inspired my daughter to want to volunteer with you guys. She starts orientation today.
Oh, really?
So you guys are doing a great job. So thank you very much. I think our patients appreciate it quite a lot. But I would certainly like to turn it over to Chad shortly. Chad, I think the service that you've started as part of getting this integrated to CRISP has been very valuable to our practices and patients. I'd like to turn it over to you to talk about this and other plans that you have for the program. Chad?
Thanks, Armani. Thank you to you and your team for putting this together. Thank you to Stacy and Meals on Wheels. I mean, they're just doing incredible work. Actually, before we get off it, Stacy, if I can ask real quick, can you comment on, you do the eligibility determination. Do you have a capacity limit that, are you able to accept new clients at this point? Do you ever have an issue with that?
No, we've not had an issue with that. And if we were, I mean, we were tested through these uncharted waters in the last couple of months. So even before this, you know, we have sort of like goals. And so our goal was, you know, to get to 1,800 clients. And so we got to that goal. And so if someone would have said, you know, are you able to get to 2,000? You know, I would have said, no, you know, we're not able to, but we just, you know, went into action and did, you know, exactly what, you know, we needed to do to keep the ball rolling. And like I said, everyone, you know, has joined in to help. And so, like I said, we're at 34, but we're also still growing. So yes, we definitely are still, you know, we've never stopped. We didn't slow down. We are still accepting applications for service.
That's great. Thank you, guys. And if you haven't seen the operation that they have in Baltimore, it's really a one of a kind. So just congratulations to you, and thanks again for being such a stalwart partner.
Thank you. You're welcome.
I'll just say a few words because I know we're getting towards the end and I want to leave time for questions. But you know, from the state's perspective, for the Department of Health, this is just a wonderful opportunity to take two foundations of improved health, primary care and community partners who are addressing these needs. We really believe the program is pinned on the belief that advanced primary care relies on taking a public health approach. And that necessitates a focus on social needs. So we've thought from the very beginning that we need to provide as much support to the practices as possible, in addition to CTOs like Netrin. And we have a statewide network of practices who are now addressing social and non-medical needs. And we think that's going to be the long-term payoff of the program for Marylanders. In terms of integration in the program, just to call out a few items, as many of you know, one of the primary pieces of addressing social needs is doing the screening and then linking patients to services that are identified, such as Meals on Wheels. This is a requirement for our Track 2 advanced practices, but we really encourage practices, all practices in the program, starting in Track 1, to start doing that work, putting it in place, identifying community partners, meeting with them and developing a relationship. Because when you meet people like Stacy, you really do want to work with them. We also are using SDOH data, social determinants data, to help you manage your population. So some of the reports that you have available include identifiers. So for example, in the pre-AH avoidable hospital events scores that you get in your CRISP reports, that includes zip code level SDOH data. So we start to incorporate that to address and identify potential risk of hospitalization or emergency department use. And then more recently, as we're all going through COVID-19 and trying to figure out how to take care of our patients and keep them out of the hospital and continue to manage chronic illness, we've added the COVID vulnerability index to that same report. And that includes SDOH data at a more granular level down to the census tract level. So we'll continue to offer those, and we'll continue to ask for your feedback and ways that we can improve services. As we think forward, we are developing a few other tools. We are working now on building a statewide SDOH platform that would incorporate the electronic referral tool that allows you to make the referrals directly to Meals on Wheels. We're also working on enhancing the electronic referral tool. Right now, it's fairly elementary, but with feedback from you and feedback from partners like Meals on Wheels, we're getting a better sense of what the needs are, and we hope to have some enhancements out this fall. The other thing was just in thinking ahead, you know, we welcome other ideas on how to enhance tools and how to enhance connections. We are happy to make introductions and develop the connections. You know, I think we started with Meals on Wheels and with Catholic Charities and with MAC Living Well on the Eastern Shore. But we're also interested in hearing from you if there are other partners that you work with on a frequent basis that you want to be able to use the electronic referral tool. We'd be happy to develop the relationship with CRISP and get them onboarded as soon as possible. So we look forward to hearing from you. We're also happy to make connections, if you haven't already, with your local area agency on aging, your local health department, and other community partners that you might be looking for. With that, I'll hand it back to you, Armani.
Thank you very much, Chad. Carissa, are there any questions, Carissa and Jennifer?
Yes, we do have a few. So I'll get started on them. If folks on the call have additional questions as we go, please feel free to submit them to us via the chat box. So our first question asks, how do you advise clinicians to ask patients about their food security?
That for Stacy?
Oh. The thing that, so for Meals on Wheels, basically the question that we ask them, are they homebound and unable to prepare meals for themselves? And we let them know too that when we say homebound, we don't mean that they can never get out, because of course, you know, we like if, you know, maybe they get out and they go to bingo or maybe church or something like that. So we just say, for the most part, you know, are you homebound and unable to prepare meals? And also, you know, and you also do not have anyone else who is unable to prepare meals, because some of the clients, they do have other people in the household for them, but they're not willing to prepare meals for them, or the meals that they're preparing for them, they're not healthy meals for them. So a lot of them recognize that, you know, they need to be eating healthier. And even for themselves, they may say, yes, I am able to buy some things, but I find myself just buying microwave things. And, you know, I know that that's not healthy. And, you know, where you guys offer a healthier solution. So I just kind of think, you know, just asking things, especially do you live alone? You know, are you still preparing meals? You know, and all those meals, do you think those meals are healthy for you? You know, and if not, here is an option, you know, and they're able to help you. They bring them straight to your door, you know, and you don't have to worry about maybe standing too long, you know, to prepare meals for yourself. One thing I can say about seniors, though, they're usually very upfront and forthcoming.
All right, so our next question is coming in from the chat box. It looks like it's several, so I'll let our presenters decide who would like to answer. How does the housing upgrade system work? Around what % of clients would you say need it? You also mentioned pregnant women have access to Meals on Wheels. Around what % of clients would you say are below the age of 60? I know that was several, so let me go back, know if I should go back and repeat. So the first is, you know, how many pregnant women are utilizing Meals on Wheels currently, and how many are below the age of 60?
Okay. I couldn't say anything definitive without running a report as far as below the age of 60. But we definitely have a small percentage who are below the age of 60. And as far as pregnant women, I've been working there for 9 years, and I probably only talked to 2, but I also think that because a lot of people do not know that that would be something that's available to them. A lot of times when you talk to people, they only associate Meals on Wheels with an elderly person and not with someone who has been discharged from a hospital where the doctor says you're not able to be on your feet or prepare meals, which is why whenever we have these discussions, I try to get that information out there so that others know that this service is available. So it's definitely not a big percentage of pregnant women, but this is just to get the word out there.
Great. So I think our next question is for you as well. It's asking about CRISP. Can I submit referrals to Meals on Wheels through CRISP? Is that what that last slide sort of went over, how to do that?
Yes. So it can be through CRISP. We do over the phone applications, and they're also able to submit applications online.
Okay, and what is the cost of meals?
So the cost of meals, it's on a sliding scale. So we take into consideration the client's income and expenses. And we also at times have certain subsidies that are available. So we have subsidies available for Baltimore City and all of the counties through the Department of Aging. That is for individuals who are 60 and over. So we have like some people who come through Johns Hopkins Bayview Elder Plus, and they actually pay for meals for clients. And we also have an in-house subsidy that our board of directors started for us maybe about, this is probably our third year, and they actually put some extra money into it for the pandemic clients, and that is for a zero fee. So of course we don't have a subsidy space for everyone, but we definitely do have a lot of clients who are on the subsidy, and outside of that, we pride ourselves in being able to work with clients where they're at. And we also accept food stamps as a form of payment. And I also have 8 individuals who are trained and can do food stamp applications over the phone, so the clients don't have to worry about having to come outside of their home.
Great. All right, so I think that our next question is for Chad. It's asking, what other social services is MDPCP planning to integrate with the program?
Very good question. If I can, I'm gonna just add to what Stacy said about accessing referrals through CRISP. If you have access to the unified landing page, the central portal for CRISP, then you can, all we have to do is make a request to CRISP to onboard you and give you user access to the tab for referrals. It's one of the tabs at the top. You won't have it unless CRISP has turned it on. But if you'd like that, we'd be happy to set it up, and I believe our Armani and your practice coach can get that set up. I'm sorry, Carissa, remind me now of the question.
It's asking, what other social services does MDPCP plan to integrate with the program?
Good question. We'd like to integrate as many as possible. I think CRISP has said they would like to expand it widely across the state into all different types of services. So in addition to Meals on Wheels, today we have MAC Living Well Center of Excellence. They offer a variety of chronic disease prevention and self-management programs. I believe they offer a meal program in partnership with their local AAA. They also offer depression programs. We have also started working with Catholic Charities on affordable housing and medical day. They're in the process of coming on. So is Giant Food. They are their nutrition program. They are interested in receiving referrals from practices across the state, as well as trainings for patients on managing their nutrition. We are also talking to some other partners in the housing arena, as well as transportation and other food security areas.
Okay, great. The next question is, does the data that Meals on Wheels captures go back into CRISP?
Yeah.
Yes, it does. I can add to that, Stacy, which is, so Meals on Wheels sends back a variety of notes in their regular feed back to CRISP, and it lets the practice know in the unified landing page for that specific patient. You would have a care alert in there, and it will tell you whether the patient enrolled, whether they made their appointment, whether they finished their enrollment, et cetera.
Okay, great. So our next question is for Armani. It asks, what other community programs does Netrin work with to help address social needs?
Yeah, so various things. One is we do take care of the food insecurity issues. And in addition to Meals on Wheels, we try to find other partners in other parts of Maryland that help address this issue. We also have partnered, Montgomery County and others, in terms of transportation, even pre-pandemic, making sure that we try to get free rides to and back and forth to the practices for appointments for the patients. So we tried to get them the transportation where applicable. It is almost at no cost to the patient if planned ahead. Our care managers get to arrange that. The behavioral health related support, social support, and then community health workers with other things in terms of a patient couldn't pay the utility bills. I mean, that happens quite a lot right now because of the pandemic. They let them not pay for a while, but even pre-pandemic, we had worked with them in areas where if patients need other enhancements to the home, getting wheelchairs and other DMEs coordinated. I remember a story of our care manager working with getting a patient a much needed wheelchair, which took us a year to get them a wheelchair that was needed, other services that were needed for the patient. This is some of the stories that I'm talking about is pre-pandemic. Right now, it's even more necessary because some of the family members are not there to physically come and help the patients. So we are trying to coordinate some of that for the patients.
Okay, great. Our next question is, I think this is for Meals on Wheels, do you transport from one county to another? So I think it's asking what your service area is.
So the service area is the counties? Is that what they're asking? What the counties?
Yeah, they're asking if it crosses county lines, I think.
So it's Baltimore City, Baltimore County, Anne Arundel County, Carroll County, Norfolk County, and Montgomery County, a small piece of Montgomery County.
And we'll include the contact information for Meals on Wheels for the rest of Montgomery County if you happen to be out of their service area for the Central Maryland Division. All right, so I'm going to go ahead and wrap us up on time today. I know that it's hard to fit in these afternoon webinars sometimes. So I just want to say thank you to everyone for joining us today. We will send these slides out after the event. We will also upload the recording of this event onto our YouTube channel, so don't forget to subscribe for additional educational content, including webinars on telemedicine, remote patient monitoring, and telehealth billing during the pandemic. We'd also like to let you know about a few things before we do close the session today. The first is that next Tuesday, August 4th at 6:30 p.m., MCMS will host a physician roundtable on the continuing challenges and opportunities presented by COVID-19. It will include perspectives from 2 primary care physicians and 2 specialists. We'll cover critical topics such as practice operations, patient communications, patient care, infection control, and telemedicine. So please visit us online to register for that event. We also want to let everyone on this call know that last Tuesday, the Montgomery County Council did appropriate $3 million to assist local primary care practices, and MCMS is urging. More details and application information is yet to be released, but please do keep an eye on your inboxes because MCMS will send that out to you just as soon as we have it. And then finally, MedChi continues to coordinate all clinician calls with Dr. Howard Haft of the Maryland Department of Health about COVID-19. The schedule has been adjusted to once a week, every Wednesday at 5 p.m. So to register for that call, please visit us online at montgomerymedicine.org. And then finally, we'd like to just say thank you so much to our speakers and our partners at Netrin Health, Meals on Wheels of Central Maryland, and the Maryland Primary Care Program. We could not have done this without you, and we thank you so much for your ongoing efforts on behalf of the county's residents.
Yes, thank you. This has been a great event. Appreciate all of the panelists attending today.
All right, thank you everybody for joining us.
Carissa, thank you. Chad, Stacy, Jennifer, thank you very much.
Thank you.